Hello, on behalf of the American Heart Association, I'd like to welcome you to today's webinar, The 4 F's of Anticoagulation Risk Assessments, Operationalizing Fall Risk Assessments. My name is Liz Olson, and I'm a Senior Quality Programs Manager for the American Heart Association. Today's webinar is possible with support from BMS Pfizer Alliance. I'd like to begin by going over a few items so you know how to participate in today's event. If you'd like a copy of today's presentation, you can download a PDF from the Handouts section of your attendee control panel. If you experience technical difficulties, most user issues can be resolved by refreshing your browser. If that does not work, please review the system requirements or contact the GoToWebinar customer service team using the system requirements link found in your confirmation and reminder emails. At the conclusion of today's presentation, you'll receive a link to access today's recording, a completion certificate, and an invitation to complete our feedback survey. We welcome you to submit text questions for our presenter at any time in the questions pane of the control panel. We'll collect your questions and address them during the Q&A session at the end of today's presentation. It's my pleasure to now introduce our speaker for today. Dr. Natalie Bradford is a board-certified electrophysiologist practicing at Atrium Health Wake Forest Baptist in Winston-Salem, North Carolina. She's an assistant professor of internal medicine dedicated to clinical cardiac electrophysiology. Her interests include atrial fibrillation management, device management, including extraction, and resident training. Dr. Bradford, thank you for joining us today. The floor is yours.
Thank you, Liz. Thank you for having me today and asking me to talk on this important topic. I think it's very important we're addressing gaps and barriers for the care of the diagnosed and untreated AFib population. For the 4 F's of anticoagulation, fertility, falls, fear of bleeding, and forgetfulness, I'll be talking about falls today and fall risk assessment. These are my disclosures. Okay. So the overview of the talk today, I'm going to be talking about fall rates, the estimated rates of falls and the expected increase over time, and some of those cost implications. I'm also going to talk about anticoagulation options and trends in our elderly population and fall patients. I'd like to talk about tools to help with fall prevention, screening, assessment, and interventions. So looking at some fall data here, this is from the Center of Disease Control and Prevention from 2018. And you can see that in the US, about a fourth of people over the age of 65 report a fall yearly. That number is even higher in our nursing home population, up to 50%. This data from the Behavioral Risk Factor Surveillance System and the United States Census Bureau shows us that in 2018, there was an estimated 36 million falls, resulting in 8 million injuries. And this is expected to increase. By 2030, 1 in 5 Americans will be over the age of 65, with an estimated fall of 52 million falls and 12 million injuries. So not only are falls dangerous, result in injuries and hospitalization, but they're costly. When we look at the costs, also from the CDC, we see that in 2014, our states were spending millions to billions of dollars every year on falls. For an average hospitalization cost is about $30,000 per fall, and it's a common cause of readmission. This equates to an overall estimated $50 billion spent per year, with 75% of these costs being from government-funded programs. So as As our patients age, the likelihood of atrial fibrillation increases, but by nature, the risk of stroke and atrial fibrillation also increases. So I'd like to highlight that most elderly patients with an elevated CHAD, most elderly patients are going to qualify for anticoagulation in the setting of atrial fibrillation. If you look at the CHADS-2 VAS score, patients over 75 are going to get two factors. And so that's patients, the males over with a CHADS VAS greater than 2 or females with a greater of 3 should be anticoagulated, including those with a history of falls. But we know that a lot of these patients are not anticoagulated. That when we look at data, and there's registry cross-sectional analysis that showed that many patients were not anticoagulated, particularly those with a lot of comorbidities or greater than 6 comorbidities. Those are patients that are high risk of falls and high risk of bleeding. And the most common cited reason that they were not anticoagulated, 31%, was because of falls or fertility. We have some tools that help us assess a patient's bleeding risk. I've listed over here to the right a commonly used tool that has blood score, but there are other tools available, hemorrhages and ATRA, and these tools are helpful for us to assess a patient's risk, maybe not to necessarily withhold anticoagulation, but to consider what we can modify. It also does help us look for alternatives. This isn't a talk about left atrial appendage closure, but that's something that we use and consider when patients' risk of stroke and weighing their risk of bleeding as well. These risk tools take in consideration the risk of bleeding, the tendency of bleeding, as in the HAS blood score over here. Hemorrhages takes into particular the risk of falls. So looking at the HAS blood score, this is maybe less familiar than our CHADS-2 VAS score. Those risk factors include hypertension, abnormal liver function, abnormal renal function, stroke, bleeding tendency, labile INR, over the age of 65, antiplatelet use, or alcohol excess. When we look at the estimated risk of a patient who falls in anticoagulation, there was a study in 1999, Markov decision analysis, that estimated that the patient would be required to fall 295 times approximately per year on a vitamin K antagonist before the risk of bleeding outweighed the benefit of thromboembolic protection. And the estimated number of times an elderly person falls per year is 1.8. So that was really strong evidence or support of anticoagulation use in the setting of vitamin K antagonist use. But at this point in time, with a lot of alternative anticoagulation, DOAC, direct oral anticoagulation, that risk may be even lower. And from subgroup analysis of patients with a fall history in our large randomized trials, like ENGAGE, AF TIMI 48, and Aristotle, they supported that the risk was low, that ENGAGE showed no change in the safety or efficacy in prior history of patients with prior falls, and lower number needed to treat in the risk patient for falls, shown here in red. In Aristotle forest plot shown here, it showed no significant difference in patients with a fall history, and overall an 80% reduction in intracranial hemorrhage in the use of apixaban. So more contemporary data, Markov decision analysis in 2012 showed that contemporary oral anticoagulation use in adults greater than 75 with atrial fibrillation in the context of falls. It estimated that persons needed to fall 35 times for no antithrombotic to be preferred over warfarin. And that number is very different from the nearly 300 number that I showed on the prior slide, But the difference is that they were using, looking at intracranial hemorrhage over subdural hemorrhage. Sorry about that typo there, but subdural hemorrhage. So that affected their number. When we're looking at a sensitivity analysis, estimated patients would need to fall over 45 times with the use of rivaroxaban, or 458 times with use of apixaban times per year for quality adjusted life years of DOAC to be lower than aspirin. And in our charts, we see that the DOAC performed better for quality adjusted life years for the probability of ischemic stroke. And as the relative risk of intracranial hemorrhage increased, it was a direct thrombin inhibitor. It was a apixaban that performed best, or at least equal to aspirin. So what about our anticoagulation choice in patients and with a history of falls? Well, this is updated guidelines from 2019 from ACCHA that support the use of NOACs or DOACs. NOACs were recommended over warfarin in NOAC eligible patients with AFib, except in those with moderate to severe mitral stenosis or mechanical mitral valve. When NOAC trials were considered as a group, the direct thrombin inhibitors and the factor Xa inhibitors were at least non-inferior, and in some trials superior to warfarin for preventing strokes and systemic embolism, and were associated with lower risk of serious bleeding. When we look at NOAC or DOAC use in an elderly population, there are some things to keep in mind. And dosing is important to keep in mind. What is the appropriate dose for your patient? I've just listed here in a table what you might want to take into consideration. That with the use of apixaban patient that's older than 80, that you want to look at their body weight and their serum creatinine on deciding whether they'll receive a standard dose or a reduced dose of 2.5. And with the use of dabigatran, that being over the age of 80 could warrant reduced dose of 110 milligrams twice a day. So atrial fibrillation association with falls. Meta-analysis have supported that atrial fibrillation is independently associated with falls and with syncope. And in persistent atrial fibrillation, in particular, there's association with orthostatic hypotension. This diagram shows some potential proposed mechanisms. AFib attributed mechanisms, autonomic mechanisms, cardiopulmonary receptor dysfunction, carotid aortic branch barrier receptor dysfunction, vagal tone, or vasovagal syncope, decreased sinoatrial response to sympathetic nervous system activation, cardiovascular mechanisms, tachycardia resulting in reduced cardiac output, hypotension, cardiomyopathy, and conduction disease, sinus node dysfunction, or post-conversion pauses. And atrial fibrillation associated mechanisms, physical factors and comorbidities, cognitive decline, vascular dementia, fertility, motor weaknesses, mobility impairment, reduced gait, antihypertensive and rate-lowering medicines, polypharmacy, and comorbid conditions such as diabetes, sleep apnea, hypertension. So the CDC does recommend we screen patients over the age of 65 for falls. They recommend we ask questions such as a patient, have you fallen in the past year? Are you unsteady? Are you worried about falling? And so they recommend these things for a patient to think about and talk about, to talk openly with their healthcare provider about the fall and risk prevention, to exercise, and we'll talk about that more later, to improve balance and strength, to have their eyes and feet checked regularly, and to look into mechanisms to make the home safer. These are some papers that can be provided to the patient for them to assess their risk of falling and for us to use as a tool for risk of falling. Has the patient fallen in the past year? Patients who have fallen before are much higher risk to have recurrent falls. Do they use or have they been advised to use a cane or a walker? Do they sometimes feel unsteady when walking? That's a sign of poor balance. Are they needing to hold on to furniture when walking at home? Are they worried about falling? They'll be more likely to fall if they are. Do they need to push with their hands in order to stand up from a chair? This is a sign of weak leg muscles. Do they have trouble stepping up onto a curb? Another sign of weak leg muscles. Do they often have to rush to the toilet? Rushing to the toilet can increase their chances of falling. Have they lost feeling in their feet? Do they have neuropathy or numbness? Do they sometimes take medicines that make them feel lightheaded? And polypharmacy and side effects from medicines that can increase their risk of falling. Do they take medicines to help them sleep aids or help improve their mood? And do they often feel sad or depressed? Symptoms such as depression are linked to falls. This is also a checklist that can be provided or used to help with looking for potential hazards at the home. So are there things in their way, objects such as paper, shoes, books, or other objects on their stairs that can be moved? Are there uneven steps that can be fixed? Is there a lighting issue that can be addressed? And can there be lights applied to regularly trafficked areas? Is the carpet loose? And can that be attached? Are there loose handrails or broken? Do they need to clear the path of furniture? And are there things that they're walking over, such as cords or wires? In the kitchen, can they put things on lower shelves? Things up on high shelves can be problematic. Are they careful or use a step stool only with a bar or avoid step stools? Is there a light in their bedroom that's easily accessible within reach? Is there a direct path to the bathroom? Do they have aids in the bathroom to help them with slippery conditions and support for the bathtub and toilet? The United States Task Force recommendations, they recommend that patients who are at increased risk of fall receive these interventions. Exercise or physical therapy. And exercise is highly recommended. It has one of the higher levels of support and evidence. And then vitamin D supplementation for those patients who are at increased risk of falls. They did not recommend automatic performing in-depth multifactorial risk assessment in those patients that were not identified to be increased risk of falls. So what are the modifiable risk factors for falls? Lower extremity weakness, balance and gait difficulties, poor footwear, home hazards, vitamin D deficiency, orthostatic hypotension, visual impairment, and polypharmacy. So looking at exercises, there has been some data that exercises reduces the risk of falls. A meta-analysis of 21 exercise randomized controlled trials, which had 7,000 patients, with the mean exercise duration of 12 months, with the most common frequency of 3 exercise sessions per week, showed a reduced risk of falling. A meta-analysis of 108 randomized controlled trials of 23,000 patients living in 25 countries showed a reduced rate of fall and reduced number of people with more one falls or recurrent falls. Their exercise types was primarily balance and focus, and resistance was preferred. And Tai Chi in particular has been one form of exercise that has been published in the literature to reduce the rates of falls by 19%. So Tai Chi, the ancient Chinese practice focusing on flexibility and coordination, is something that's highly recommended for patients at risk of fall. And a meta-analysis of 10 randomized controlled trials analyzing the effect of Tai Chi versus usual care showed a median protective effect, at least for short term, of 12 months. Vitamin D supplementation. The data is mixed in the results for vitamin D supplementation, but in general, it's recommended if a patient is at risk of low vitamin D and falls to go ahead and supplement. Those patients that are thought to be at risk are those with a low vitamin D diet, low sun exposure, history of malabsorption, slow gait speed, difficulty rising from a chair, and poor balance. And the empiric supplementation is 800 to 1,000 IUs. The risk of harm is thought to be very low, except for very high doses of vitamin D supplementation. So overall, fall management takes a comprehensive management strategy. Analysis of a home safety assessment and intervention, vision assessment and intervention, and polypharmacy review. So this requires a collaboration of primary care physician to help us assess falls and fall risk, and a collaboration with experts or specialists to help with home safety. You can use the assistance and should use the assistance of occupational therapy. And perhaps with a polypharmacy review, the assistance of the pharmacy, our pharmacy colleagues. So in summary, atrial fibrillation prevalence and the fall incidence is increasing with an aging population. Most patients greater than 75 years of age with atrial fibrillation should receive oral anticoagulation, and DOACs are preferred to vitamin K antagonists in most patients, regardless of the history of fall. Risk assessments and interventions to reduce fall risk should be offered with a collaborative healthcare team. Here are my references. And I'll leave you here with a picture of an ancient Chinese exercise program that maybe we should all be involved in now to reduce our risk and increase our flexibility and coordination. And I'll hand it back to Liz, and thank you.
Thank you so much for leading today's webinar. It's my pleasure to now introduce our moderator for our Q&A, Anmol Dalwadi, Quality Programs Manager. Anmol.
Thank you, Liz, and thank you, Dr. Bradford, for your presentation. Dr. Bradford, I have some questions here. With the impact of COVID and the increase in telehealth services, have you had to modify your process for conducting fall screenings or educating your patients of their risks?
Yes, with COVID, we've all had to make some adjustment in our practices, and I think we are relying much more, particularly in the beginning, with telemedicine. And so a lot of those screening tools that I listed are things that are readily available to patients and family members with internet access. So some of those tools available are for the CDC, and those can help us kind of judge with the patient and the family, patients that are at higher risk of falls, and get information and a detailed history about their fall history. And with that information, we can help make referrals to those other members of the team that can maybe go out to the home and help address things that we can look for to reduce the hazards at home and communicate with pharmacy and then try to limit some in-office exposures when that was of the highest concern. And I think that's changed the way all of us have practiced, maybe for the future as well, and given us more options, particularly with patients that may have less mobility.
Great, thank you. For many older adults, many have comorbidities or deconditioned because they have been unsuccessful in addressing modifiable risk factors. What are some ways clinicians can encourage and collaborate with patients to participate in interventions? For example, rehab, PT, medication adherences.
Yeah, that's hard. That's a hard question to answer, because it sounds like the person who asked the question said, you know, they've been working on modifying risk factors. Now they're trying to encourage the patient more to be involved. You know, I think part of it is developing a good rapport with your patient, and you know, providing education and talking to them repeatedly about what the risks are of atrial fibrillation and stroke, and why it's important that we reduce their risk of falls, but also protect them from the risk of stroke. And talking to them in detail, maybe over multiple visits or televisits, and including family members can be very, very valuable. Maybe saying, well, can I, you know, may I call your children, may I call your loved ones? Maybe we talk to them as well about the plan and some of these options, and then letting them know that there are people that can come to them and can help with some of these interventions, and they're not the only ones that need this help, and just kind of working through those strategies kind of gently but supportively.
Thank you. On the topic of educating patients, educating patients and empowering them to make their own decisions or having a shared decision-making conversation is important. As we think about risks and benefits of anticoagulations, what are the greatest risks and what are the greatest benefits for the patients?
Well, when we think about the risk and benefits, that is an in-depth conversation. Okay, that's talking about what their estimated risk of stroke is. And we estimate that generally based on their CHA2DS2-VASc score. Okay, so we're calculating with them what factors they have that put them in increased risk of stroke. And I know we're all familiar with that, but that's congestive heart failure, hypertension, age, diabetes, stroke, vascular disease, being a woman, a female gender, and age is counted twice, 65 and 75. And then the second question you ask is, you know, what are their risk of bleeding? What makes them high risk of bleeding? And that's where some of those calculators that I provided earlier, the HAS-BLED score, helps us kind of estimate this risk. And we can look at this from our CHA2DS2-VASc score. This is your estimated risk of stroke. And this is what a potential stroke could lead to. These are, you know, disabilities, and these are some signs and symptoms and things you should be aware of. And then on the side of the bleeding risk, these are some things that you should look out for if you're on anticoagulation or in general because of the risk of bleeding, and calculating those risks and comparing them. So lots of those there are several of the factors that are in the CHA2DS2-VASc score or in the HAS-BLED score, and there is some overlap there, that those patients are at risk. And I hope I answered your question. You could repeat it if I didn't quite answer all of it there.
I think that was great, and thank you. And we have one last question here. It says, you mentioned that exercise and specifically Tai Chi reduces risks of falls. How do you build confidence in your patients who may think they're too frail or worried about falling to participate in these activities?
Yeah, you know, that's difficult as well, right? Because if they don't have the confidence, if they're fearful of falls, it's hard for someone to think about getting involved in an exercise program. And that's where I really go to the guidance of family members or other patients or physical therapists or people that have, can help them kind of feel confident and know that they're in a safe position to do these. And sometimes it is building up to that level of confidence. Maybe it is starting with, I often tell my patients, low level of exercise for short periods of time for most days of the week, if you can, and observed exercise in someone who's feeling uncomfortable with the risk of falls. And you can use programs such as cardiac rehab or physical therapy where, that observation is by a medical professional.
Great. Well, thank you so much, Dr. Bradford. I appreciate your time today. This has been very insightful. I'm now going to turn it back over to Liz.
Great, thank you. Well, thank you, Dr. Bradford, for leading today's webinar, and thank you all for your participation in today's event. After today's webinar, you'll receive a follow-up email with a survey on the presentation, and we would love it if you would complete that and provide your feedback for us. In that email, you'll also receive a link to view a recording of today's presentation and a certificate of completion. On behalf of the American Heart Association, thank you for joining us and have a great day. This concludes today's presentation.